Thank you very
We
much.
switch on to the third session of the day. See,
Thank
when
you.
most of us at our age had started learning the gastroenterology practice, we were taught how to do ultrasonography, how to do an endoscopy. But somewhere down the lane, 10 years later, early in mid-19th, there was a marriage between endoscope and ultrasound. And we had a birth of a new super speciality called endoscopic ultrasonography. We had the doyen of EUS, Dr. Robert Hayes and Dr. Sham Vardharalaju, who had been regularly visiting India, and initially it looked to be pretty cumbersome and non-rewarding procedure. But down the lane, over the last 2 decades, it has become the integral part of practice of gastroenterology. And now we realize how is it that we learned gastroenterology without learning EUS. To take us through the journey of EUS, especially the recent advances over the last 2 years, we have none other than Professor Michael Wallace, who is the leading EUS expert in the US, and Dr. S.S. Rana is going to us to take through the journey of EUS, the recent advances. Dr. S.S. Rana, please.
Thank you, sir. Good morning, Mike, and good evening to all the audience here in India. It's indeed a privilege and honor to moderate a session by a leading expert, Professor Michael Wallace, whom we, as we all know, as a chief editor of GI Endoscopy. He is Fred C. Anderson Professor of Medicine and Director of Digestive Diseases at Mayo Clinic in Jacksonville, Florida. He has served as an associate editor of gastroenterology, and he has a number of laurels and awards to him. He has more than 350 peer-reviewed publications, and he's going to speak to us on recent advances in diagnostic EUS. Although we have been learning a lot about interventional EUS and how it is making big strides in the field of GI endoscopy, but diagnostic EUS also silently has made bigger strides, and it again has a major role to play in future in the practice of gastroenterology and endoscopy. With these few words, I hand over the mic to the Mike Wallace, who is going to speak on recent advances in diagnostic EUS.
And Dr. Surinder, may I again request you to please stick to the time for the other speakers to be sticking to the time.
Yeah.
Very good. Thank you very much for that very kind introduction. I will focus largely on the last few years of development, but history is also very important. And I'll begin with the very beginning of endoscopy. Over this next 20 minutes, I'll cover the increasing role of EUS in screening for pancreas cancer, recent advances in EUS tissue acquisition with improved needle designs, other advances in enhanced EUS imaging. I'll focus on some recent work in elastography. And lastly, we'll turn to a very exciting area of the role of EUS in liver disease, including both traditional methods like liver biopsy, variceal therapy, and a very recent addition, the use of portal vein and hepatic vein pressure measurement, allowing really a comprehensive evaluation of the liver. So in the beginning, which was actually more than 40 years ago now, the first 2 reports in the world of an endoscope married to an ultrasound device were reported. One from Japan, and one, I'm happy to say, from the Mayo Clinic in Rochester by the famous pancreatologist Eugene DiMagno. As you can see, the instrument was very difficult. It was very blunt. And both of these investigators determined after these initial studies that EUS would never become a useful technology. And this instrument was put in the closet for more than 10 years until it resurfaced with smaller endoscopes. And most importantly, as was highlighted in the introduction, the advancement of needle-guided EUS or EUS-guided needle procedures really was the major breakthrough that brought EUS into the mainstream. So I'll turn now to several topics, beginning with pancreas cancer. The most common indication in our practice, and I think throughout much of the world for EUS, is for tissue biopsy. And particularly focusing on pancreas cancer, up until perhaps 10 years ago, there was some debate if we needed to do a biopsy at all. If someone had a pancreas mass and malignant obstructive jaundice, they needed to go to surgery. But that has changed in the last 10 years. We've really shifted our treatment for pancreas cancer, and in fact for several other cancers, to a neoadjuvant therapy, where the patient gets chemotherapy before surgery. And to get chemotherapy, you have to have a biopsy. And that has driven much of the demand for endoscopic ultrasound. In addition, several other diseases which can mimic pancreas cancer have also surfaced, most notably autoimmune pancreatitis. And it's often a tragedy to see a patient with an enlarged head of pancreas go to a Whipple resection when the final pathology is only autoimmune disease that could be treated by simple corticosteroids. In aggregate, patients who present with pancreatic masses, about 10 to 15% of these are not surgical disease, emphasizing the need for preoperative endoscopic ultrasound and biopsy to characterize what disease they have. Also, in very recent years, the ability to do very focused genetic sequencing of tumors has opened up a new area of precision therapy. And these can now be performed on standard EUS guided needle biopsies, particularly with the new specialized needles for biopsy, which I'll cover in just a moment. We now have many different needles available. They generally fall into two categories: the traditional fine needle aspirate needles and the new fine needle biopsy needles. And we're currently in our third generation of biopsy needles. And really, this is where we've seen the most dramatic change. The first two generations of needle biopsy instruments were largely small incremental change and difficult to use. However, in this third generation, which involve at least 2 or 3 prongs at the tip of the needle, this allows large tissue acquisition very efficiently, often with only 1 or 2 passes, and allows gaining sufficient tissue for histology as well as molecular classification. This is one of the early reports from our group about 4 years ago, a case control trial in 156 patients who were sampled with the so-called shark core or fork tip needle. These were compared to a matched group of 117 patients. You can see here the difference in the concept. The standard FNA needle has a single bevel, and the tissue, some of it goes into the needle lumen, but much of the tissue slides along the outer surface of the bevel. With the new Franseen or fork tip needles, the tissue is funneled into the needle lumen, and so a much larger specimen is obtained even for the same size of needle. You can see here some of the bulk specimens on the right. You get true histology with these, so you can perform all of the normal histological staining. And in this study, this is the one that I mentioned, we've shown that we can reduce significantly the number of needle passes, typically from 4 to 2. And in many cases, actually with the larger needles, like a 19 or 22 gauge needle, only 1 needle pass is necessary to obtain a sufficient specimen. Overall, the yield for histology is significantly higher with the fine needle biopsy. This is on a single pass. 95% of samples had histology versus only 59% with traditional FNA. And you can see the very bulky specimens that are obtained, which are easily amenable to supplemental studies such as immunohistochemistry and molecular profiling. This is a nice study from Shyam's group in Orlando, Florida, a randomized trial of the 2 currently available Franseen or fork tip needles, one from Boston Scientific, one from Medtronic called Shark Core. And overall, these are largely equivalent. In this trial from Shyam's group, you can see the total tissue area, the total tumor area, the tumor to tissue ratio, and the desmoplasia. All were very similar between the 2 types of needles. So I think both of the new currently available FNB needles work very well and are quite comparable between the 2. This is a recent study that our group completed, a randomized trial of FNA versus FNB with the fork tip needle. The order was randomized, but all tumors were sampled with both needles. They were evaluated with a standard histological score, and then we performed DNA quantification for whole exome sequencing on the samples. What you can see is that there was a significant increase. Now, 92% of FNB samples had histological quality specimens versus 42%. This is very much in line with our retrospective case control study. Overall parameters for tumor cellularity also strongly favored fine needle biopsy with more tumor cellularity. A common commercially available genetic sequencing assay called Foundation 1 was also 78% of samples on a single pass. We could perform this genetic analysis. And also the final biopsy. Now, both samples were very good for final biopsy. So we can get a biopsy-proven cancer with either needle. It's these supplemental materials that are most helpful. You can see also the DNA yield was significantly more. This is in nanograms per microliter, almost 6 nanograms per microliter of DNA with the FNB needle, which is about twice that with the FNA needle. And now actually with modern sequencing, both of these samples can be subjected to DNA sequencing technologies. Let me now turn to screening for pancreas cancer. We focused much of our screening efforts in the GI world on colorectal cancer, as well as esophageal squamous cell and adeno, and to some extent on gastric cancer. But pancreas cancer has not traditionally been one that we screen for. However, there's an emerging opportunity to screen for this very, very fatal disease. In the United States, at least, only 9% of individuals survive the diagnosis of pancreas cancer. And the survival is, like other cancers, very dependent on stage. However, unlike many other solid cancers, even stage 1A and 1B disease have very high mortality. You can see in these survival curves that less than half of even stage 1A patients will survive out to 6 to 5 years. So we really must diagnose pancreatic cancer at its very earliest stage, ideally at stage 1A, or even better, high-grade dysplasia. How should we do that? Well, we know from other cancers that we first need to define a population at risk. This should be done with less invasive or non-invasive tests such as blood biomarkers, stool biomarkers, or family history. This is followed by an enrichment phase, and this is where EUS is most valuable, using EUS and MRI, followed by a biopsy confirmation. Does this work? Well, there's an international consensus for cancer of the pancreas screening called CAPS. It's enrolled a large number of patients looking at this model for screening for pancreas cancer with the goal to detect T1N0 or high-grade dysplasia. Patients were enrolled who were at high risk based on family history or known genetic syndromes or cystic lesions of the pancreas, and they were screened with MRI and endoscopic ultrasound. The yield was quite high, particularly for cystic lesions. Almost 40% of these 225 patients had cystic lesions, and about 1.5% had solid tumors. These are really the ones we're looking for, as well as the high-risk cystic lesions. So yield is relatively high. If we look overall, do these patients then progress to high-grade dysplasia? And the answer is yes. About 7% overall progressed, or about 1.5 per year. This is, for example, substantially higher than the rate of progression in Barrett's esophagus. And importantly, about 93% of lesions had detectable lesions without worrisome features before their diagnosis of cancer. And if you look at the survival, this mimics other diseases that we screen for. If we catch them at this very early stage, high-grade dysplasia, we can cure the vast majority of these. Even the invasive adenocarcinomas that were detected during surveillance had substantially better survival than those that were detected based on symptoms alone. So I think we do have emerging evidence that we can screen for pancreas cancer and potentially make an impact. Let me now turn to some of the emerging technologies for early detection and classification. And I'll focus on EUS elastography for purposes of time. We now have multiple methods that enhance our image with endoscopic ultrasound. And one of them that's available on many of the modern EUS instruments is called elastography, and particularly a form called strain ratio. Since we cannot estimate the absolute tissue stiffness, what we do is we typically compare the stiffness of a region of interest, for example, the tumor, to the stiffness in an adjacent normal area, which can either be adjacent normal pancreas or the wall of the intestine. This very nice study from the group in Italy, published a couple of years ago, shows substantial separation between the strain ratio between malignant lesions, neuroendocrine lesions, and inflammatory lesions. So I think although this will not replace biopsy, it will help us distinguish this very difficult question we sometimes face. Is this an inflammatory mass, an autoimmune pancreatitis, or a malignant lesion? So to summarize how we're currently screening for pancreas cancer, first we identify individuals at increased risk based on family history or genetic testing, also new onset diabetes in a patient who's not gaining weight. We can identify those at intermediate or high risk. Those at intermediate risk get further enriched by MRI, blood, or stool tests, and at high risk for endoscopic ultrasound and MRI. And it's really in this high risk group where we have good evidence now that we're making an impact in identifying patients who have curable disease unlike those that present with symptoms and a large mass. I'll touch briefly on pancreatic cystic lesions. These have been very well studied over the last few years. There's a few new diagnostic issues which are important. This is a typical patient, a middle-aged female who presents for a CAT scan for other reasons, and they identify this cyst in the body or tail of the pancreas, and you're asked as a gastroenterologist, should we sample this? Unfortunately, the guidelines and dilemmas are still quite significant. We ask, is this mucinous, serous, or non-neoplastic at all? Is it malignant or likely to become malignant? And how should we manage it? Should we resect it, observe it, ablate it, or do nothing? The patients often are very worried. They hear about a pancreas neoplasia and they think this is cancer and they know that that's a fatal disease. So they're going to ask you, should we just reassure them, or should we really tell her what is probably the truth? We really don't know what is the major risk, although our knowledge is gaining very rapidly in this area where we can define that risk. Unfortunately, we also have multiple guidelines that are somewhat conflicting, although they generally do agree on the highest risk lesions. The highest risk lesions that require invasive sampling and potentially surgery are main duct disease, especially main duct over 10 millimeters. Intermediate risk would be main duct 6 millimeters or more, a jaundice patient, or anyone with a solid mural nodule, or an FNA that shows suspicious or malignant cytology. Pancreatitis or other symptoms are a relative indication for invasive evaluation, and cysts greater than 2 centimeters also are a relative indication for invasive evaluation, such as EUS FNA. Also, increasing size and the threshold value has been set at 2 millimeters per year. Serum elevated CA19-9 is controversial, but in some cases may be helpful, especially if it is rising. So just to summarize the current data on cysts, the current guidelines all have fairly limited accuracy when compared to surgery. Surgery and EUS FNA can find up to 12% of patients with missed high-grade dysplasia or cancer because of the somewhat modest sensitivity of our current imaging and even biopsy. But most of these lesions are high risk and can be followed expectantly. However, there is a small subgroup, particularly those I outlined before, such as the larger cysts and main duct cysts or mural nodules that are high risk and should be followed very closely or offered resection. There are a couple of new methods for diagnosis of these lesions. I'll focus on the through-the-needle microforceps. The data on confocal is still somewhat controversial in my view, and pancreatoscopy is sometimes reserved for distinguishing a benign dilated main duct versus an IPMN main duct lesion. These are new forceps that are currently available. They've been studied for the last couple of years. They do significantly increase the yield of tissue. These are passed through a 19-gauge needle, and you can now get histology with these through-the-needle forceps. And they have been shown in cohort studies to increase the overall diagnostic accuracy compared to fine needle aspiration alone. However, there is a significant risk of bleeding and pancreatitis. I'll now turn to a new field, EUS hepatology. And in my last area, I think this is really an exciting area given the very high and rising prevalence of liver disease throughout the world. I think EUS can play a central role in the diagnosis of liver disease because it really offers a one-stop option to evaluate almost all components of liver disease, from liver biopsy, elastography, contrast enhancement, ascites aspiration, paracentesis, and even most recently, portal vein sampling. So compared to our current approach, where we typically do a diagnostic endoscopy for variceal assessment and other radiographic or interventional radiology assessments for fibrosis, measuring portal pressures, diagnosing lesions, paracentesis, endoscopic ultrasound allows us to do all of these procedures in a single step, offering significant convenience and efficiency to the patient. We've been able to do liver biopsy for quite some time. It's especially useful in the very obese patient where percutaneous liver biopsy is often not feasible, but it's really quite feasible in all patients who need liver evaluation. We have very good evidence that we can obtain high quality liver biopsy specimens, especially with the newer needles. We can get the large samples, 2 to 3 centimeters in length with a large number of portal triads. This was a meta-analysis looking at the overall yield of liver biopsy, which showed it to be quite effective You can see the overall pooled rate of successful histology of about 94%, a pooled rate of insufficient specimen of about 10%, and a pooled rate of adverse events of about 2%. This histologic yield is likely actually higher than this with the newer type fork tip needles or Franseen tip needles that I showed earlier in the pancreas. We also now have emerging, in fact, established evidence that we can treat gastric varices through EUS-guided interventions. This is likely preferred to blind cyanoacrylate injection, and particularly the advent of coil therapy or coil therapy combined with glue is a major recent advancement. This was a randomized controlled trial of 60 patients who underwent coils alone or coils plus glue. There was a significant improvement in all parameters, including immediate disappearance of varices, a significant reduction in rebleeding, and a significant improvement in reintervention rates. And a further systematic review of this topic again showed very high efficacy of coil plus glue. And I think this is emerging as the treatment of choice for large gastric varices, particularly the isolated fundic varices. In the last slides, I'll turn to the most recent advancement in diagnostic EUS, EUS-guided portal pressure measurements. This was first reported in 2017 with successful portal pressure gradients measured in 28 patients. The readings are taken from direct 25-gauge needle puncture of the portal vein and hepatic vein with a direct difference or gradient calculated as opposed to the estimated gradient, which is obtained from hepatic vein wedge pressures. There have been no adverse events reported in this series, and the time is relatively quick, less than 30 minutes for these procedures, and they correlated very well with traditional measures of portal hypertension. This is the technique count. Now, this device was just recently approved in the United States. We puncture the left hepatic vein or middle hepatic vein from the GE junction. It's a 25-gauge needle with a pressure transducer. Then secondarily, we puncture the portal vein and measure the pressure in the portal vein and calculate the true portal pressure hepatic vein pressure difference. This is the small pressure transducer, which is just hooked to the back of a standard EUS needle. We just started performing these in our hospital. It's quite simple and safe for people with experience with EUS-guided needle puncture. So just to summarize, EUS is a well-established method of choice for pancreatic tumor and cyst biopsy or FNA. It has emerging roles of supplemental methods such as elastography, cyst fluid biomarkers, cyst microforceps biopsy. We now have good evidence that the new fine needle biopsy devices are superior to fine needle aspiration for histology and DNA yield, and an expanding role for screening patients for pancreatic cancer. And I think there's a large potential for expansion in the EUS hepatology area. Thank you very much.
Thanks, Mike, for an excellent presentation and an updated overview on recent advances in diagnostic EUS. And as you have rightly said, it's an upcoming field. There are a lot of great advances happening, and diagnostic EUS is going to stay in clinical practice with these advances in place. So we have a panel with us who is going to take through us in the next 10 to 15 minutes. We are going to discuss your talk and the recent advances in diagnostic EUS. So we have Dr. Ajay Bhalla with us. Is he there? Yeah, he is there. Okay, yeah. So as Mike talked about the role of EUS FNB needles, and FNB needles seem to be much better than FNA needles in all the aspects. So do you think that FNA needles are obsolete? They don't have any role in clinical practice, considering the cost factor, especially in developing countries like ours?
Yeah, I think Professor Wallace has already kind of driven the point home, but the EUS tissue acquisition is constantly undergoing development. There was a time when FNA was considered the gold standard, but currently with the approach that we need to have, where we need to acquire better tissue, the tissue acquisition is poorer in fine FNA needles. And also, if you do not have rows available, rapid on-site evaluation, which is not available in most of our centers, I think FNB would be far more superior. And it has been proven that third generation, the one with the crown at the tip, have fewer passes. The duration of time is less. Also, the diagnostic yield, the histological specimen, is far better. So I don't think, earlier what was thought to be as a salvage therapy, that if FNA fails, then you have to think of FNB. But I think now it will be primarily the first line technique, FNB, for all solid lesions. It's still not there, but I think it's going to come very soon on record as the one which is going to provide us the right tissue.
Okay, thanks, Dr. Ajay. Mike, what do you think? Is FNA needles now should be put laid to rest and it's all FNB all around? No role for FNA?
Well, clearly for cystic lesions, there's no advantage of the FNB needles, and they're about 1/3 the price of an FNB needle. So for cystic lesions, we're still using traditional FNA needles. For routine lymph node biopsy, we also still use FNA needles, unless we're concerned about lymphoma,
That's right.
where histology is particularly valuable. But if I'm just trying to determine if a node is a metastases from a pancreas cancer, a traditional FNA needle is sufficient.
Yeah, I agree. I think the cystic lesions and lymphadenopathy, other than lymphoma, FNA needles still may be used considering the cost factor, but other places, FNB needle is probably is better than FNA needles. Next is Dr. Sanjay Gupta is there. Yeah, he's there. So Dr. Mike talked about an image enhancing techniques like contrast, EUS, and EUS elastography. But considering the fact that majority of times we'll have to acquire the tissue, do you really think that these techniques are of any clinical utility? They are not just fancies; they really help. What do you think is your experience or your recommendation based on practice in India?
Actually, I am not doing this elastography and contrast EUS in routine. But I feel that these have a role definitely if the lesions are small, particularly between 1 and 2 centimeters. So if the lesions are small, the needle need to be, the directed biopsy need to be taken, and I think that is one of the best. Specifically, if you have got a failed FNB earlier, then also it is wise to take this one. But because of the logistics, the cost involved, additional cost involved in the procedure, this cannot be. First of all, this cannot be practiced as a sole procedure, and subsequently, and the other thing is biopsy is still needed, and these procedures still not been, they've been not been quantified to be the sole diagnostic modality without a biopsy. So therefore, they should be restricted and should be used only when they are required in our setting. But yeah, now the cost of the contrast is actually coming down, so we can use it more frequently.
Right. Thank you, Dr. Sanjay. Mike, what do you think? Is it just colors and fancies? Do they really add on to the clinical utility? Because, as you have rightly said, doing an elastography and contrast doesn't need any special training. It just softwares are needed. But do you think that the cost is worthwhile, subjecting the patient to these investigations in routine clinical practice?
Yeah, I would classify these as emerging technologies. They're not yet really established. I think the potential areas where they're useful and where I use them in these screening patients that we don't know that they have a tumor, often there's some subtle findings of chronic pancreatitis, even a small lobule. You'll see a 5 or 6 millimeter lobule, and I'm unsure if it's a lobule in chronic pancreatitis or is this a 5 millimeter tumor. Those are the cases I've been using, particularly elastography. Also, sometimes there's a small nodule within a cyst, and I'm not sure if it's a globule of mucus or is it a true mural nodule. And in those cases, seeing that there is flow with contrast material can distinguish between a mural nodule and a mucin globule. So those are very niche applications, but at least for me, some useful areas for these technologies.
Yeah, and maybe to add on to, sometimes in gallbladder you find some small polyps, or whether it's a sludge ball, there also probably the contrast may help you in differentiating between the two. But I agree with you that these are emerging technologies, and we still need to do a lot more before they can be, firmly established in clinical practice. Dr. Ashish, you heard Michael Wallace talking about a lot of advantages of EUS guided liver biopsy, that in one go you can do so many things, but we still don't find that EUS liver biopsy is doing so well in clinical practice in India. What do you think is the reason? One obviously is the cost of the needle, and very limited people do the procedures. But do you see any significant hindrances in bringing EUS liver biopsy into routine hepatology practice?
Thank you, Professor Roy and Professor Rana. Definitely, US guided liver biopsy. We have certain advantages over the conventional liver biopsy technique, like its diagnostic yield is comparable, even superior, and we can biopsy focal lesion in a better way because of better quality of image. Patient comfort is better, recovery time is shorter. So overall, conceptually, it's a better option than previous techniques available. Real problem is cost. We are working in a government setup, so if we compare the percutaneous versus US guided liver biopsy, so it's somewhere between 10,000 in percutaneous approach versus 20,000 in US guided approach. 20,000, why I'm saying, because we are using it as a patient, we are doing in a conscious sedation, not doing in a general anesthesia, and we are reusing the needle biopsy, FNB needle, we are reusing it, FNB needle. If you are, and along with that, we always plan to do screening endoscopy at the same go. So if you have planned for the screening endoscopy in the same go, and in that case, it can be comparable cost effective, comparable cost. And a study have shown if we add this endoscopy, another endoscopy procedure along with the US guided liver biopsy, then cost is relatively comparable. And in our setting, still there is a gap between the percutaneous liver biopsy cost and US guided liver biopsy. But cost can be reduced if we use the conscious sedation and if we reuse the needle, which is actually usually do in our country, unlike the West.
Thank you. Mike, what do you think is the reason that US guided liver biopsy, even at the best centers in the world, is not being commonly performed? It is still, if you look at the papers, last 2 years, only the number of papers have gone up, but still it is not being seen as a frontline modality for obtaining liver tissue in hepatology practice.
Yeah, I agree with Professor Jha's comments that if your only purpose is to perform a liver biopsy, a percutaneous is a less costly, less invasive way to go. However, the way we see this is a typical liver patient is going to radiology to get an ultrasound in the elastography, and in some cases a biopsy. They're going, in some cases, to interventional radiology to get a hepatic vein pressure, and then they're coming to endoscopy to get a variceal assessment to see if they have large esophageal or gastric varices. The major cost advantage here and efficiency advantage is we can do all three of those things in a single conscious sedation procedure. So the patient really can get a comprehensive evaluation of their liver in a reasonably cost-effective way. We do need more evidence that this is truly cost-effective, but I think this is likely the pathway that we will go forward. We've just started in our liver program to offer this service of a single upper endoscopy EUS biopsy, and if needed, in fact, a patient who doesn't have large varices, we will do a portal pressure measurement to see if they're at risk for developing large varices.
Yeah, that's right. And in your practice, do you use a 19 gauge or a 22 gauge third generation FNB needle for liver biopsy?
We use either a 19 or a 22. I think the 25 gauge needles are a little bit too small to get a good specimen. I do prefer the 19 gauge. There's some evidence that it gives a superior specimen, but this is not completely resolved yet. And
do you sample both the lobes or one lobe?
Yeah, we sample both the lobes, so there is good evidence that there is better yield for fibrosis and inflammatory markers if you sample both the right and left. So we do the left from the just below the GE junction, and we do the right from the duodenal bulb.
Thanks, Mike. We have Dr. Pradeep with us. Just one question. I was just wondering, artificial intelligence is making such big headings in all the field of endoscopy. We were listening to the previous lectures where they were talking about polyp classification, NBI magnification, and how AI is making a big difference there. Do you think AI is going to make any difference in EUS?
Well, sir, thank you for having me, sir, into the discussion. Good evening to you all, and good morning, Dr. Michael. Sir, whenever a marriage is there, I would like to put in that manner, the offspring usually come out a bit late. And as the children grow up, they go into different fields. Same is the word with artificial intelligence. The subset is basically, machine learning. And the another subset of this is basically the amount of deep learning which you can have it. artificial intelligence cannot replace a human brain because it has been again made by the humans only. So we definitely learn, keep on learning new things. It will definitely help as a synergistic application, in aiding you whenever you are confused somewhere. Like, if the duct is not clear, the intramural nodules are not very much clear. If you have got a cystic and a solid lesion, together where you are not able to find out what exactly it could be, that will aid you side by side, but it can never, ever, replace a human brain. So it is our brains, which have definitely done it. Now I've been doing, these cases for last around 5 years, after learning for 5 years continuously. So we realize that every day is a day of learning. So we need to, artificial intelligence is definitely good, but it cannot replace. Like, FNA needle cannot be replaced because just before cystic lesions, FNB definitely gives you a good yield of biopsy.
Thanks, Dr. Pradeep. Mike, what do you think? There were a few papers, I think, in last 6 months where AI was used for differentiating between GIST and leiomyoma, and then EUS AI for focal hepatic masses. So do you think AI and EUS is future?
Yeah, I have no doubt this will be the case. We've seen the AI companies first went for what we call the low-hanging fruit. The low-hanging fruit are colon polyps because this is such a large market. However, the fruit that is going to come next, I think, are all the other imaging fields, including endoscopic ultrasound, even ERCP, pancreatoscopy, cholangioscopy, and certainly all of the radiologic fields are moving quickly towards AI enhancement. We're already seeing, as you mentioned, US AI assistance in GIS. We actually have 2 papers that are going to be accepted soon in GIE related to liver lesions and pancreas lesions. So we're already seeing this coming. Any image that can be classified by a human, we can use AI to assist that. The most likely targets are going to be the things that are difficult right now, distinguishing low risk from high risk mucinous lesions, distinguishing chronic pancreatitis in its early forms, and even liver lesions that are sometimes difficult to classify.
Thanks, Mike. I think we are just finishing time. I just have one question from the audience. One has asked that, do you do a EUS guided liver biopsy in moderate to severe ascites?
In moderate to severe ascites, by definition, this patient has cirrhosis and significant portal hypertension. So it often is not necessary unless you're trying to understand the cause of the cirrhosis. We already know that they have cirrhosis. It is feasible to do it in ascites because often the ascites, there's minimal ascites in the gastrohepatic ligament area. So you have maybe even a better window for biopsy than a percutaneous, but only in the setting where you need a diagnosis of the type of liver disease. Is it PBC or PSC or alcohol or fatty? Because we already know they have cirrhosis.
So in that situation, would you prefer a transjugular or an EUS liver biopsy if you have a, say, severe ascites?
I think right now the standard of care probably is transjugular, but we are seeing this emerging role of EUS, and I think it'll likely continue to emerge as a significant role.
Right. Thank you so much, Professor Michael Wallace, for an excellent presentation and participating in this discussion. And I thank my co-panelists, Dr. Ajay Bhalla, Dr. Ashish Jha, Dr. Sanjay Gupta, and Dr. Pradeep Agarwal for participation in this panel discussion. Thank you so much. And I hand over back to Professor Anil Arora.
Thank you.
Dr. Arora, you have to unmute it, Dr.
Thank you, Dr. Surinder. I am grateful and thankful to Professor Michael Wallace and all the expert panel members for having taken us through this journey of diagnostic endoscopy. The live-in relationship which started between the endoscope and ultrasound about 30 years ago has blossomed into an excellent, well-settled marriage. Now, believing that gastroenterology can be practiced without EUS is making a fool of yourself. And I'm really impressed with the way Professor Michael Wallace has given us that in a patient in hepatology practice, if you just have one tool, it has to be EUS, because in one tool, you can make a diagnosis of fibrosis in the liver, you can look at the varices, you can look at the portal pressure, and who knows in future, you may be able to do a TIPS using an EUS guided procedure. With that, I thank all the panel members and the moderator and speaker for the excellent presentation.